All right, folks, welcome to EMS Challenge. We're live at Birmingham Fire and Rescue Station 1. Thanks for having us here. Super appreciate the opportunity. This is our last class of the year. It's good news and bad news. The good news is for everybody. The bad news is that research starts like in January and you got to March. So if you don't have your Con Ed, it's probably time to get that going. But I'm going to talk about some I know that for the general paramedic, a lot of labs, you don't utilize those unless you're doing something in a facility. I think some of this is good to critically think in the hospital and utilize labs. Realize not that you got to use all the tools lab to take care of the patient. So hopefully it'll be semi-beneficial. Disclosure required to do. Remember, we provide EMS Con Ed for free, your nursing CEUs, and for the docs online, we are approved as well. So official disclosure. Back in January, we're in Calera, and then Springville, we're in Helena, and then Trussville, so a lot in the Brems region, at least looks like until March, and then we're back up in Huntsville and in some other locations. So we had a good turnout at our cadaver lab last week. The next one will probably be scheduled for the first week of May, and I'll post that on Eventbrite when it gets. This is my unofficial disclosure slide that I use other places besides EMS Challenge. So for those unaware, we started this program back in 2014 to bring more physician-led Con Ed out to EMS. You say it once, you've heard me say it several times. What paramedics do, physician-level care. And we as mainstream healthcare should step up and support you both in education and Con Ed and feedback and in resources for what you do. All right, let's talk about some labs, and I'll try to keep the humor semi-friendly today. Out there for you guys doing critical care in a facility that you can look at, my suggestion is that you always, as you're doing your physical exam, getting a quick bedside report. Mike's not working. All right, my suggestion would be that as you're getting your bedside report and there's inter-facility transfer report, you're doing assessment, checking your vitals, trying to recognize if that patient's sick, is there any life threats you got to address immediately, that someone of your crew, you or your partner, are thumbing through the labs. One of the benefits of the Obamacare was that it required documentation, required everything to be electronic. The downside is that in transferring that documentation, so you go from online document source to paperwork, and it gets cumbersome, and it takes a few minutes to dig through. But some of these labs are super important. So the first one we'll talk about is a HCG, obviously for pregnancy. There's 3 types you can get. You can get 2 types of blood tests. There's 1 type of urine test. The urine test we do is a screen. It's about probably 95% accurate, pretty accurate. So it's the same you get at Walmart for 99 cents. You can get it at RER at 2 o'clock for $5,000. So it's a great deal for you guys, right? Works about the same. Very few false positives with that. You get a couple of false negatives, but they're rare. We can do a blood test that works on the same chemical reaction as that. Costs a little bit more, but it's done by blood. We use that in the hospital for folks that are critically ill. We got to check a pregnancy test. We can't get a urine from them. We can usually get these results back in less than 10 minutes. There's been some bedside testing for that. The quant, the HCC quant, gives you an actual number of hormone. We utilize that to kind of determine viability. So a lady who is pregnant, and her quant on day 1 is 2,000. In 2 days, that should double. We can kind of trend what's going on with them. So if they come in with belly pain, we get an ultrasound of the baby that's kind of atypical. We can't really figure out what's going on. We may have them come back in 2 days, repeat that quant. If that quant is doubling, know that the baby is growing appropriately. If that quant is not doubling, or it's going to know that we have probably an intrauterine fetal demise, and this would be a poor outcomes. Good test to have. The other reason we wanted to make sure anybody of childbearing age has a pregnancy test is because if you have a pregnancy, that changes some of the medications and therapies that we can do. And we have 2 patients, right? By childbearing age, say, 6 to 6, right? I've seen folks as young as 9 get pregnant, and I had a 54-year-old in the ER one time that was pregnant as well. So crazy world we live in. So 6 to 60 is the rule that I usually use. And I even check some guys as well. Ha 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 ha. All right, thanks for almost laughing. The BNP, so there's some tests we can do to look at heart function. There's the troponin, which is the gold standard. There's the old troponin, which is troponin I and a CK and a CKMB. And the BNP has been around probably 15 years or so. We use it pretty frequently. The BNP is a test that looks for heart stretched, and it gives you kind of cardiomyopathy or congestive heart failure. Obviously, if your patient is hypertensive, volume up, setting 80%, and looks like an flash pulmonary edema, duh, they have congestive heart failure. I don't need to get a blood test to tell me that. But if I'm looking to kind of stage where they're at for CHF, or I'm screening them out to say, are they high risk for having a dysrhythmia? If they're passing out, does it make me uncomfortable because they're CHF? This BNP will give me that information. A pretty useful test. You can actually do these at bedside too. You can get an ISTAT test as well and do that. And before the question comes up, yes, there are some agencies that can use these. I know some flight crews carry them. The problem in our state of Alabama is that if you do any kind of bedside testing except for glucose, you have to have a license from the state laboratory board, whatever they call that. So that kind of makes it challenging as far as the red tape. Otherwise, folks would have those, I do believe. But that's the BNP. The D-dimer is a screen test that we use to look for blood clots, whether you have a vein thrombosis in your legs or pulmonary embolism. It's more of a screen tool for people who are low risk that is like, yeah, but you have just enough of a history that makes me uncomfortable. I'm going to screen you. If that D-dimer is positive, then we do a diagnostic test that's the gold standard, which is a CT angiogram for PEs or an ultrasound for the legs for DVTs. You get a lot of false positives with these D-dimers. We kind of joke in the hospital like we're going to roll a D-dimer dice because we know we're going to get a lot of false positives. So before we check this, we got to make sure that we think, all right, the risk is enough to check it, and we're going to get a CT angio if it's positive because you get a lot of false positives with this. What the D-dimer is basically looking for is clot breakdown. And you may be thinking, why do you have clot breakdown in a blood clot? Remember, we talk about the reason we use TXA because when people bleed out, the body makes clots. Then the body goes back to that clot and says, hey, do we need to keep this clot or kind of break it down? The body starts breaking down a clot and hemorrhage. Then it says, oh, well, crap, we're still bleeding. Make that clot again. Does the same thing if you have a pulmonary embolism or a DVT. You have that clot that's made that breaks it down a little bit and it says, oh, we got to keep that clot, and it builds it back up. So you can check for rapid breakdown products is what that is. Timers looking for. So you can imagine we do get a lot of false positives with this. We'll talk more about the CK, MB, and troponin here in a few minutes with a few cases. The other labs that we like to look at that are screen labs are the basic metabolic profile. Some people call it a SMA7 or a Chem7. It's just basic electrolytes, right? Gives you a lot of information. Basic labs. I like Oprah. All right. So sodium, one test to look at. Sodium, normal is 130 to 105. Kind of give dehydration status. Water follows sodium. So if you're working out, really sweaty, you may drop your because your volume down. Chloride, really, from my it also is a volume thing. 97.08 is the normal I use in most labs. But really, I don't even care about it. The only time I get concerned is if I look at a sodium level with somebody and their sodium level is greater than 108, let's say it's 120, I start thinking, why in the world would somebody's sodium be so high? Excuse me, chloride. I'm talking about chloride here. If the chloride is so high, I start thinking, why will the chloride be high? And most of the time, it's due to the fact that somebody's drawing blood from somebody above an IV. So you got an IV with normal saline in it, sodium chloride, run it in their wrist. We draw blood from AC. What are we getting? Sodium. Yeah, we're getting the fluid, right? Sodium chloride. So that'll really screw up the labs. And if you start treating a patient based upon those labs, you can actually hurt them because the labs are not correct. That was chloride, not sodium, sorry. Potassium. I know y'all probably talk about potassium at EMS Challenge a lot. Here in the Deep South, hyperkalemia is a very bad thing, and we see a lot of it. If I'm talking about. So hyperkalemia, Textbook says greater than 4.5 or 5 abnormal. When about so you start seeing EKG changes, but in reality, it's based upon that patient. So we had a guy this weekend whose K was 5.4, which is just a little bit elevated, and he had major EKG changes. They were not used to that. You may get someone who has chronic renal insufficiency and gets dialysis 3 times a week. So every 3 days, their K may be 7, and their body is used to that, and their EKG is normal. So we get concerned with hyperkalemia when it changes the EKG because that is life-threatening. If it's not changing the EKG, it's concerning. We as physicians or critical care transport medics it and be thinking of treating it, but the EKG change is what's going to kill you dead pretty soon. So the 3 S's for hyperkalemia, I won't go fast over this because I know we talk about it a lot, is stabilize, shift, and excrete. So inappropriate humor, I missed the slide. So stabilization is with calcium chloride, calcium gluconate. You can start shifting with albuterol, and that can be done as an EMT level. So even if the EMT shows up at a dialysis center and you got somebody who's got slow and wide rhythm, the bradycardic, that EMT should think, dialysis center, renal failure, heart rate slow, they're probably in hyperkalemic. They can start some albuterol. In the hospital, we're going to do insulin and then dextrose. And we give them insulin that kind of opens up receptors in the cells so that in addition to glucose, that potassium goes back in, right? So it decreases hyperkalemia. But if we don't give them glucose, we can take them from glucose of 100 to hypoglycemic, and that's bad. Now, the good news is in Alabama, how many folks are that you see? Everybody, yeah, roll tide, right? Good, good. So a lot of times these guys' glucose may be 600 already or 200, and it's not going to hurt them. It might actually make them smile. And then we can excrete the a couple of ways. Dialysis is an easy way. The problem with that is that dialysis, even in an academic shop like UAB, it's going to take us several hours to get somebody dialysis. So we have to shift that potassium medically first. Medicines out there that you can give that lower the potassium cause a lot of GI distress. Kayexalate is the old school one. There's a new one out there that kind of looks like that guy. Actually, his sister really, but it's Lokelma, and it doesn't cause as much GI disturbance. But my point to that is if you're working at a place and you're transporting somebody who's got acute renal failure from hospital A to hospital B, you want to make sure you shift that, that potassium before you get on the road or get in the air. What you want to do is you don't want the hospital to shift it with Kayexalate or Kelma before you get in the air on the truck, because what's going to happen in the helicopter or the back of that rescue is that diarrhea, and that is not a good day for anybody, especially in the air. So this is an EKG. The machine reads the rate at 191. Does anybody agree with that? Nobody's going to say anything. Bueller, I do not either. No, the machine is picking up the QRS complex and the T wave. So we got peak T waves, but more importantly, we got a Y complex QRS. Our QRS is almost 300. There's no PR interval, so it looks like AFib, but it feels pretty regular. This is hyperkalemia, okay? So if you're transporting somebody, you look down and you're reading through your labs and their K is 6.2, you should be saying, hey, did y'all treat this hyperkalemia and with what? All right. And then you should be looking at that EKG that's going on right now, not the EKG from 45 minutes ago. You should look up at that 3-lead Y complex QRS. Is it slow? Nope. If it's not, great. Roll tide. Get me a 12-lead, and you're looking for Y complex QRS and no PR interval. If that's still there, guess what? They get more calcium, more albuterol, more insulin, more dextrose, but no more of Kayexalate or Kelm. Cool. So this patient got treated. This is their EKG. That one is at noon. That one is like just before 8 o'clock in the morning. So this patient got albuterol, got some fluids, got calcium, got insulin and dextrose. And you can see we can take them from this EKG to this EKG by correcting their potassium. Crazy, right? Cool. This one is high risk. If you go to intubate this patient and get a vagal response, they can go into VTAC or VFib. If you're popping an NG tube in them, if you're dropping the power lift stretcher too hard, huge risk for going into dysrhythmia. If this patient goes into VTAC, you're going to think, rightly so, oh, defibrillation, amio, lidocaine, airway management, ACLS algorithm, which is great in VTAC, but not in VTAC that's caused by hyperkalemia. You got to shift that K or they're going to die. Complete blood count, the CBC. There's all kind of components to this. You can get a differential and things of that nature. Don't tell my boss, but I really only look for a few things on a CBC, right? So I'm looking at the white blood cells. White blood cells fight infections. If you get a lot of white blood cells, it makes you think there's an infection going on. Sometimes more concerning is if someone looks sick, they look infected, and they have a low white blood count. People say, okay, because it's not elevated. Actually, that's not okay. That means they can't mount a response and fight off their infection, okay? But lots of things can make you have an elevated white blood cell count. White cells hang out on your blood vessels, so when you have a stress response, those white cells release from the blood vessels and go out to fight infection and whatever else is going on. So you'll see an elevated white count in trauma patients, and that's because they're under stress. Their body is, all right? They're not infected. They're just jacked up from their trauma. You'll see this in people who get steroids because steroids are released naturally when you have that fight or flight response. Or if I have an asthmatic or somebody that goes to an urgent care with a cough and cold and they get steroids, you'll see a huge white count pop on those guys because those cells are coming off the walls of the vessels, not so much to fight an infection, but because they think they may need to. So you get a lot of false positives. We can look for something called bands. Bands are new white cells. Those are ones that are being made, not off the walls, and that's in that differential we look at. Oh yeah, this dude's got a fever. His leg looks swollen. Could it be a DVT? It could be. I could check a D-dimer, right? I'm going to get some basic labs. And I say, oh, look, his white count 34,000, way too high. He's got bands. So that means his body is already making new white cells. So this has probably been festering for a day or so. Yeah, he's probably sick. Cool. The hemoglobin is the blood carrying capacity of the body. Some docs use hemoglobin. That's the actual number. The hematocrit is a percent. Some docs use hematocrit. It used to be easier. You could do a bedside hematocrit 20 years ago. You could spin it down and look at it quickly. You can get either one of these back pretty fast now in a lab, probably less than 10 minutes if your lab efficient. Hemoglobin is like blood pressure. First one gives you baseline, but it doesn't give you the whole answer. You got to check them in serial checks to see what kind of trending you got going on. For example, if I had a trauma patient came in with an amputation of a leg, tachycardia, pale, the heart rate's 40, blood pressure is 80, and I draw labs on this guy, his first hemoglobin is probably going to be normal or normal-ish. He hasn't had time to dilute his blood down. So, for example, if I take this grape juice, right, and I pour half of it out, in the bottle, it still looks like grape juice. That's like the hemoglobin. We, as providers, as we recess them and we give them fluids, it's going to dilute down, okay? So sometimes people get burned. They'll say, oh, I got this GI guy some blood. He's tachycardic. It looks like dirt, but he's not really bleeding because his hemoglobin is fine. I would argue that is a false statement. First hemoglobin does not count. And that, you know, was he anemic before he started crapping blood or got shot? Okay? As I give him fluids, I'm going to repeat that hemoglobin in a few minutes and see what it looks like, and you're going to see it trend down. In reality, I'm going to give him blood products, so hopefully it doesn't trend down. Platelets kind of indicate how well you can clot. So too many platelets can lead to a clotting disorder. Those will usually have some kind of blood cancer. More concerning is the low platelets. So platelets less than 50,000 should make us uncomfortable, especially in transfers, hemorrhagic injuries, or head bleeds. Platelets less than 25,000, you can actually have spontaneous intracranial hemorrhages from them coughing, sneezing, things of that nature. We could do some liver labs on people, and I got nurses from different generations here, except I don't have the one from Wards. I don't have Florence Nightingale. Sorry, sir. Thank you for smiling. Good, good. There were no smiles there. So liver does a lot of things. Liver gets blood supply from two different places. It gets it from the aorta like everybody else. And then you have the portal system as well. So anything that you put in your mouth hole that goes to your stomach and your colon is absorbed and goes to the liver through the vessels through there. So anything that is bad, any poisons, any alcohols, all go to the livers and can damage the liver. But the liver does a lot of things. It makes proteins, it makes clotting factors, it binds toxins, and helps makes enzymes that help for glucose control and well. So liver is super important. And one of the things you see a lot of times in folks, trauma victims, people who are septic or post-cardiac arrest, you see acute liver failure due to poor perfusion. So knowing if the liver's working is super important. So liver function panel has a lot of labs on it. And again, a lot of these, as an ER doctor, I don't really care about in the acute setting. Things I do like to think about, albumin. Albumin is a protein that keeps the fluid you give someone in the blood. If their albumin is low, if I give them a couple of liters of fluid, it doesn't do any good. That fluid goes into the blood, then into the interstitial, and you get third spacing. So these guys need extra albumin. We can give that to them. A lot of times it's chronic liver people that have these issues, but albumin's important. Low albumin can make you have third spacing of fluid, so they get ascites, the big belly, all right, because you got free fluid in the belly because of that. A lot of times they're prone to getting peritonitis infection because hanging around this fluid is the colon, and what hangs out in the colon? Yes, that stuff hangs out in the colon, huge risk of getting infection, right? Okay. Calcium is also bound to the albumin, so low albumins make you think that the calcium may be low, and it kind of messes up our lab test. We have to get a special ionized calcium to make sure it's correct. That can lead you astray. And then you got the bilirubins, you got the indirect, direct, the total. There's a protein that is absorbed from the colon, and then the liver conjugates it, and then you can pee it out. If the liver doesn't work well, you can't conjugate it and make it water soluble. So people turn jaundice, and you can see these liver folks have jaundice. All right. So, and nobody's got my inappropriate humor yet, so I'll make it a little bit bigger. And nobody still got it, but you get a smile because you're scared I'm going to ask you a question. So, but total bilirubin is what I usually look for because that gives me an idea. Okay, if the total bilirubin is greater than 2 or 3, liver's got some kind of insult. If we're getting up in the 10s, they're probably going to be yellow as I'll get out, almost like Marge Simpson, right? And we're going to have all kind of problems with that. And that gives you an idea that the liver's not working. If the liver's not working, I know they're going to be third spacing of fluid, so I have to be careful how I resuscitate them. I also think liver's not working, they're not going to have good platelets, right? Bleed, so if it's a trauma, they're higher risk for bleeding. It just kind of gives you insight to figure out, what should I do for this guy based upon their labs? Why don't I have that? Oh, ammonia is something else that the body clears through the liver. Ammonia is a byproduct of any kind of protein. So if you eat protein, you build up ammonia. If your liver works well, that ammonia is converted, you pee or poop it off, no problems. If your liver is not working, that ammonia builds up. Ammonia crosses the blood-brain barrier, and people are confused and altered. Okay? GI bleeds, people have GI bleeds from diverticulitis, from varices, from other infections. That's actually feeding the colon. Blood is protein. So if you bleed into your gut, it's giving yourself your own natural protein, right? So your BUN goes up, your ammonia goes up, and you get encephalopathic, confused, and altered because of that ammonia. Coagulation profiles, we can check how fast it takes your body to bleed. We can use the PTT, kind of looks at the drug heparin we do. The PT looks at other drugs like Coumadin or overall clotting factors. INR is the way to kind of stabilize. And then the anti-10A is for newer drugs. So did y'all go over clotting cascade and paramedic program here? Yes, no? Y'all did. Oh, praise God. That's fantastic. Good. I thought y'all may have got lucky. So this is a very interesting pathway here. I got a tattoo of this actually. It's on my right calf. So if I forget it, I can go back and look at it right now. This is a tough crowd. All right. Oh my God. So we memorize this in med school, and I think there are points to this that are important, okay? But it's, 12 goes to 11, goes to 9. You hook up 9 and 8, it makes 10 get excited to make 10A, which makes prothrombin make thrombin, which then makes a fibrin clot, and then goes to a cross-linked clot, right? So super important stuff, right? While all this is going on in the blood, we also have calcium and platelets swimming around. Without those things, it doesn't work. That's why we give calcium in our hemorrhagic shock when we're giving blood to people because they're bleeding out. And then they have other proteins we don't even know about yet, other things in the plasma that help make this clotting cascade. And the goal of all this is to make a clot, okay? So that's my thoughts of this really deep down. It's confusing. But the important thing to remember is that we give people medications that jack up this clotting cascade. So there's Coumadin out there for DVTs. There's Xarelto, things we use people that have AFib or have mechanical valves or the post-stents or post-stroke. A lot of folks in the Deep South are on these anticoagulants. We make a drug now called PCC that actually fixes these, reverses it, and makes them go from a free bleeder to a normal person again. All right, so PCC is factors 9, 10, 2, and 7. So if somebody's on Coumadin for a blood clot, it jacks up those 4 factors so they bleed freely. They don't make that clot. If they're hit by a car, if they fall and hit their head, if they're crapping blood from a GI bleed, we don't want them to bleed that freely because they would die. So we give them this PCC, and we flood this algorithm with these extra parts. So therefore it overrides everything, and we make clots. Eliquis, Xarelto works on this 10A, okay? But we can still give them that PCC because it floods it and makes more factor 10A that's not messed up by the Eliquis or Xarelto. So that is my redneck way to explain clotting cascades and why it's important. Platelet activation, a lot of folks are on aspirin. Some take Plavix or Brilinta. Remember, aspirin, all these things, what they do is really take this platelet and then make it with a platelets cannot adhere. If the platelets don't stick together initially, then you can't make that clotting cascade. Nothing really works. So that's why aspirin is so important in STEMI evolution and things of that nature. So platelets, I imagine them as like these cells, have these little probes on them, right? And those little plungers stick together and force themselves. Aspirin, Brilinta take away the functional kind of appendage that attaches on there. Blood gases, I know that a lot of critical care guys talk about ABGs, things of that nature. ABGs are great to learn. You got to understand acid-base balance. But in reality, they hurt patients. Nobody appreciates them. In today's world with end-tidal CO2, SAT monitoring, and basic labs, you don't really need them as much, is my opinion. So I'm not a big ABG guy. So that's why I say gas X. Yeah. Maybe somebody online is laughing at my humor. Maybe they're not. I don't care. Cardiac enzymes, obviously the 12 lead is the first cardiac enzyme you want to look at. You can have someone having a STEMI right in front of you and your labs are normal. They still go to the cath lab or they will die. Old school was we got a CK, CKMB, and a troponin. Okay, the CK is what your muscle breaks down, extreme stress, exertion. If I was a marathon runner and I ran a marathon, my CK would be elevated because of muscle breakdown. Okay, a portion of that CK is MB band. That is the tongue and the heart. So we used to get CK, CKMB. If the MB portion of the CK was high, we would be thinking, we got some kind of upper airway issue versus we got cardiac involvement. When troponins came around probably 15 years, 20 years ago, data looked at this is isolated to just the heart. It took a lot of troponin build up for us to recognize someone was having a heart attack. Now we can do high sensitivity troponins. That's kind of the gold standards. So you'll get people that have, just advanced age that go out and walk up steps and you get a troponin level and it's elevated. Doesn't mean they're having a major heart attack, but it lets you know they have some kind of underlying heart issue. So this is the gold standard right now that we use. But again, it takes about 90 minutes to 2 hours for that troponin to build up enough for us even to find it. So if I had a dude that came in having chest pain, his EKG was normal, I'm not going to say you're not having a heart attack. I'm going to say, hey, your EKG looks good. Your first labs are great, but this has only been going on about 90 minutes or so. We got to repeat this lab test at 2 hours at least to make sure that troponin's not elevating. Okay, that's why for EMS, the non-critical care, the guys working in the streets, taking care of patients, if you got someone that's having chest pain or an ACS equivalent and you do a 12 lead on them, you can't say you're having a heart attack. Say, hey, your EKG looks reasonable right now, but those things change. But there's no way to say you're not having a heart attack without getting some more labs. And I can tell you as an ER doctor, sometimes I have somebody that has a normal EKG, a decent story. I get 2 troponins at 0 time and 2 hour time. It's normal. I'm still concerned. I admit them for a stress test and even more diagnostic workups. And I would say sometimes those guys are still ended up having a big MI. So never underplay cardiac stuff. Lactic acid. I know a lot of folks talk about lactic acid. It's a great screening tool. Somebody once said it's the troponin of the body, but in short, if your lactic acid level is high, that means your body is not perfusing for some reason. The question is, what is that reason? So if I go out and have 6 PBRs and some nachos, all right, I'm going to get dehydrated and my lactic acid would go up. If I go out and run a race, same thing. If I'm septic with a urinary tract infection and I'm dying in front of you, my lactic goes up. If I'm shot in the streets of Birmingham and now my heart rate's 140, my blood pressure is 90, my lactic goes up. So a lot of things make it go up. The trick to a lactic is, can we clear it? Does it get better over time? So if they have had a seizure and they're altered and I get a lactic and their lactic is 15, which is abnormal, greater than 2 is abnormal, I think, they probably had a real seizure because their body was working out. They got metabolic acidosis for a few minutes. Wonderful. I give them some fluids. I manage their airway. I'm checking for other labs that are scary. I'm doing a 12 lead to make sure they weren't having arrhythmias. All right. An hour later, they're perking up. I repeat a lactic. If their lactic is now normal, I don't care about that first lactic. It seems reasonable to have a lactic acidosis. If I repeat in an hour and the lactic is still 12, now I say, okay, it wasn't that seizure they had an hour ago. Something else is driving this, and they're probably critically ill from something else. So I start looking for infections, making sure the blood pressure is fine, and things of nature. All right. So if you're transporting a patient from hospital A to hospital B, you're going to look at those trends of that lactic acid. You're going to scroll through there and say, oh, crap, Mrs. Jones' lactic was 14. Oh, but look, the nurse said that her blood pressure was 80 when she got here. She got 2 liters of fluid, got some antibiotics. Now she's on Levofed. Her blood pressure is 110. I wonder if they got a second. Oh, they did. Look, oh, it's gone up even higher now. It's 9. So you should be really concerned about that well-being of that patient, or they're going to code on you, versus, oh, Miss Jones's lactic is now 1. Great. We fixed the underlying problem. We're making her better. So can you clear the lactic is the question you got to ask on these transfers. Semi-inappropriate humor for the inpatient folks. I know you guys in Birmingham see this every day, probably at the fire station, right? Yeah. Yeah. All right, so let's do some cases if I got time. This is a transport from hospital A to hospital B. It's a 60-year-old male. They have a history of hypertension, diabetes, and coronary artery disease. What does that tell you? They're a Bama fan. All right, yeah. Or Georgia. The report at bedsides, this patient was having chest pain for about 3 hours. They were weak and pale, were short of breath. The vital signs were open. The initial EKG was not a STEMI. The hospital A gave them aspirin and heparin. Aspirin works on platelets. Heparin is a blood thinner. Anybody having what we think ACS, acute coronary syndrome, STEMI, or an NSTEMI, gets at least aspirin and heparin, because we want to make that part of the heart that's being occluded, that clot not get bigger, right? So look at our labs. Sodium is 135, normal, right? So like 130 to 140-ish. Potassium is 4.5, that's normal. Chloride, don't really care, but I can look at it. Bicarb is 25, that's in the normal range, they're not acidotic. The BUN is 18, I don't think I mentioned BUN earlier. BUN is blood urea nitrogen, and it's a protein that you kind of measure, and it gives you an idea of how the kidney is working. Creatinine is the other indicator. So a creatinine less than like 1.5 means your kidney works at 100%. Higher than that means your kidney is not functioning well. You can use the BUN to kind of tell you, are they dehydrated? Is that why the kidney's jacked up? Or is it intrinsic kidney problems that won't get better? So you can look at that lab and say, your kidney function is off today, but I think based upon your labs, it's going to recover in the next couple of days versus probably not going to recover. So their kidney function looks good. Their glucose is 120. The hemoglobin 11, so up to 15 is normal. 11 to 15 is fine. Hematocrit, I don't really care about that. Some folks do. White cells are 8, so not a big stress response. Platelets are 300, so those are normal. And our high sensitivity troponin is 798, so that's abnormal. So If I was the transporting team, I would say I'll get my history, get my vitals, make sure they got that aspirin and the heparin. And the next thing I'm going to do, y'all should know as well, what's the next thing I'm going to do before I start moving this patient to the new hospital? I'm going to look at that EKG to make sure I believe it's not a STEMI, because if it's a STEMI, it changes everything. Now we're on metrics, on times, bad things happen. So I'm going to look at the EKG, right? And I'm going to realize that they had chest pain for 3 hours, right? So maybe this is okay. So I'm going to ask that transferring facility, hey, would you guys draw another troponin for me and send it? You don't wait for it to come back, but by the time you get to your other hospital, you got that second troponin, and it gives the new doctors an idea of what's going on. If that new troponin is 800, yeah, we're going to watch them, do a cath the next day. Well, we care deeply, but we're not going to be very anxious, right? If the new troponin comes back 24,000, we're going to quit eating our pizza and take them to the cath lab, okay? What if, same patient, but on your physical exam, their blood pressure is 220 over 110, they sound wet, their head bobbing, they're breathing 24, 30 times a minute, and they say, oh, their BNP is also 350. What's going on with this patient? CHF, yeah, they're in pulmonary edema, right? So yeah, they got CHF based upon this number, but clinically they're in pulmonary edema. So what do we do for those folks? In addition to aspirin and heparin, what else do they need right now? Nitro and CPAP, yeah, just like we do in the field, yeah. I'm gonna say, great, your blood pressure is way too high. EKG wasn't a STEMI. I'm gonna send them up. Hey, nasal cannula the nose, CPAP over the face. If you're a flight crew doing critical care, they get BiPAP, but if you don't, they get CPAP. And before I put that mask on, I'm gonna pop a nitro under their tongue. If you're a critical care, you might pop 1 or 2 nitros under the tongue, right? You want to lower that blood pressure, right? The other thing I start thinking about now is, maybe this troponin high because their blood pressure is sky high and the heart's working hard because they're full of fluid. So I start thinking, maybe it's not ACS, maybe it's just congestive heart failure, all right? But I still treat them like it is. Cool. What if same patient, but instead of the blood pressure 220 over 110, the blood pressure is now 88 over 58, but they're gurgling, huffing and puffing and full of fluid. What do they get? Do they get CPAP and nitro? No, because if you give them CPAP or nitro with this blood pressure, what happens? Yeah, you get to work a code, man. You can bill more for that, right? But it's not good. Yeah, so this is where it gets scary. So at this point, the critical care guys are going to have to think, all right, well, I can't do CPAP, I can't do nitro, but I got to do CPAP or they're going to become more hypoxic and die. So this is where we may do some levofed, get the blood pressure up. At the same time, if you're at that hospital and you're critical care and you don't carry it, maybe you ask for some dobutamine or some milrinone to increase that squeeze to get the blood pressure up. No way in dirt do I give them nitro, right? Cool. But you may have to give some push dose neo or do some levofed to get the blood pressure up for them to tolerate the BiPAP. Cool. Talked about that. Now here's a same scenario. Chest pain, chemistry labs look great, troponin high, but you look at C and the hemoglobin's 4.2. Is that too high or too low? Low, right. So why would you have heart problems if your hemoglobin is low? Because you don't have any hemoglobin. Yeah, you can't carry oxygen to the heart, right? So instead of giving them heparin and aspirin, that's when you say, hey, doc, I need to give some blood to this guy. The hemoglobin is 4. Have you addressed that? All right? So I've seen several older people, mature patients that come in weak and dizzy, and we get an EKG on them because they're weak and dizzy, and their EKG looks like a big freaking STEMI. All right? We start getting our workup, we're doing this stuff, and they go, and I've been crapping blood for the past 4 days. We get a hemoglobin, the hemoglobin is 4. They don't need a cardiologist. They don't need blood thinners. They need blood. You give them 3 or 4 bags of blood, and they're like smoking a Black and Mild. They're feeling great. EKG is normal at that point in the game. All right. What is this one here? This is a similar scenario, except now our exam is they're tacky. Some people say that's hypertensive. I say that is normal for Alabama. Sats low, but they're wheezing. All right. Sodium was okay. Potassium is 5.6, a little bit high. So I'm looking at that EKG. Bicarb is reasonable. Creatinine is 3.7. BUN's 23. That tells me that if this ratio is not 20 to 1, then this is probably intrinsic kidney problems. So this patient probably has chronic kidney disease. We're going to have to shift that no matter what because they're not going to be able to clear it. Glucose is 270, so they're just an Alabamian. So they're not in DKA because the bicarb is fine. H&H is low but stable. So you can pick up a lot of things just by looking at those labs. Inappropriate humor. How much time we got? All right. This is a respiratory distress, recent URI, now worsening cough and shortness of breath. They're COPD, they smoke. You got noticeable labored breathing when you walk in the room to transport this patient. And they call out, they gave you an ABG because it's old school there. They don't have end tidal. pH is 7.19, CO2 is 70, O2 is 185. So CO2 on blood gases is just like the end tidal. So 35 to 45 is normal, so they're retaining CO2. pH 7.35, so 7.19 is too low, right? O2 is over 100, so don't care, all right? If they were still hypoxic, I'll still give them extra oxygen, so that it doesn't really matter to me, but they're retaining. So this patient needs BiPAP, critical care, making the transport. If you're not, they're getting CPAP. They need nebs, right? If they haven't got it already, they need steroids like we do in the field, and a couple of grams of magnesium. And they need to be on waveform capnography for your transport, and that will kind of guide what you're doing with them. So, not sure what the guns mean, because I guess we're in Birmingham. Other things you can think about in that patient that you get those labs on, we could say that her sodium is 135, is 2.7. What person with COPD have a potassium that is low? What did you do to that patient to make their potassium low? Anybody? Bueller? What drug do you give somebody that's having COPD or asthma? Albuterol. Albuterol does what to potassium? It lowers it. We use it for hyperkalemia. So you might see their K is a little bit low. I wouldn't worry about it too much, all right? Because when you stop that neb treatment, that's going to get better. But it's something to think about. And if you're doing a long transport, maybe you do ask that physician, hey, can we get an order for some maintenance fluids and some potassium? But you got to look over here. Creatinine is up. BUN is up. So she's got the underlying kidney disease. You got to be careful and stopping her neb treatment to make it too high. All right. Care about bicarb is 32. That's a little bit high. Why would a person with COPD have an elevated bicarbonate? Yeah, they're already always metabolic acidosis, so their body is compensating. They make more of this stuff, so they can live with that CO2 at 50 or 60 normally, right? Glucose is fine. Hemoglobin is up. White count is up. All right. Probably due to hemoconcentration. Maybe they're just dehydrated, or it could be due to COPD. They make more red cells because their body thinks they're hypoxic, but they're hypoxic because they've been smoking black and mild since 1972. Troponin's up a little bit because they're older and we're smoking. These are significant coronary artery disease. BNP is all due to the smoking history. Lactic is 3.7. Concerning. And we want to wait for the second one. Can we clear it? Can we not clear it? If we clear it, great. If we can't, we got problems. ABG. Here's another one we see a lot, and this is a patient who is obese, has a history of sleep apnea, a lot of health problems, maybe some COPD. Now they've been confused by the family, they say, for a couple of days, and now they're breathing 6 to 8 times a minute. Their sats are low and they're twitching. What's going on with them? Your end tidal CO2 reads like 90. If you're transporting this guy from the hospital and they got a blood gas, CO2 is greater than 110. Yeah, I'll say respiratory acidosis. Yeah, so what's going on is these folks who have sleep apnea, they get a little bit sedated from Norcos or drugs or alcohol or too much turkey at Thanksgiving, right? They slow their breathing down, their CO2 gets high, it gets so high they get more confused, slow their breathing down, and they get CO2 narcosis. A lot of times these guys, you'll see them kind of twitching. That's what kind of gives it away, right? That and your capnography. Obviously, you're going to sit them up. You're going to do a complete assessment, get them naked, look for life threats. You're checking a glucose on them. You're running a 12 lead. You're starting an IV. You're going to open the airway and assist ventilations. But they need positive pressure ventilation for a while to blow this off. And the cool thing, a lot of times, these guys, sedate them, intubate them, put them on the vent for like 30 minutes, and now they're wide awake because we fixed their CO2 problem. But the good news is, in the ER, if they're intubated, guess what? They still get admitted. They leave my ER. All right. Nobody smiling. Let's keep moving. 35-year-old, history of recent GI bug, type 1 diabetes or insulin dependent, glucose read 400. You're going to transfer this patient from a freestanding ER back to the mothership. Heart rate's 123, blood pressure is 98, breathing 34 times a minute inside 98%. Their sodium is 130. K is 6.5. If you see a K is 6.5, after you use profanity, what should you do as that transporting medic? Look at the 12 lead. Yeah, look at the 12 lead. Some people say, well, I'm going to look and see is it hemolyzed. Because remember, if the blood is ruptured, they draw the blood too fast, they shake the tube up in the lab. A lot of times they'll call back and say it's hemolyzed. And what that means is those cells are ruptured and you get an abnormally high potassium. But I say, who cares? The next thing you do is look at the EKG. Because if the EKG is normal, I got time to do other things and figure out what's going on. If the EKG is abnormal, I'm going to sit them up, do albuterol, get calcium, and they're going to get insulin. And this patient probably doesn't need glucose because they already have hyperglycemia. Cool. Chloride, don't care. Bicarb is 8. That is way too low. That person is acidotic. So they're in diabetic ketoacidosis. BUN is 34. Creatinine is 1, so kidney function is great, but that BUN at 34 is more than 20 times the creatinine, so that tells me this is all dehydration. So they're way volume down, so I'm slamming a couple liters of fluid into them. Hemoglobin is 19, probably because it's concentrated because they're so dehydrated. You can throw your end tidal on this person, and the end tidal is going to read low. So breathing fast, SAT's great, end tidal, it's not a respiratory problem, it's a problem. Cool. So 12 lead fluids, they're 35 in a diabetic. I'm getting a trope. Sometimes folks at that age with diabetes can have ACS. They need insulin, dextrose, they need calcium. I'm probably going to do a bicarb infusion because their bicarb is low as well. Sweet. Same patient, except now their glucose is 170. So end tidal's 13, breathing fast, blood pressure's low, the labs, and the doc says, yeah, I think they're septic from something, maybe a GI bug. Are they sick or not sick? Well, the bicarb is 8, metabolic acidosis, decay is up, sick as dirt. Could it be DKA? The glucose is 170. It still can be, yeah. Actually, we see more and more of this now. It's called normal or euglycemic DKA. There are a lot of medicines out there, that you can take for diabetes. So type 1s use their own insulin. There are other medications that are approved for type 2, but you'll see them being used for type 1s as well. The most common is these SLG2s. This is a medication that makes you pee off extra glucose. So if I'm a diabetic, I'm a type 1, and my glucose is running 300 all the time, even with insulin, the doc may put me on this SLG2, so that way I pee off glucose. So instead of having a 300, normally I have a 100. But because I'm type 1, I got to have insulin. Sometimes they're going to DKA even with a normal glucose. And it will burn you as a physician sometimes or a critical care medic. This walks like DKA, looks like DKA, except the glucose is normal. You got to start figuring out what other medicines they're on. So these SLG2s like Invokana make you pee off your glucose so you get a reduced glucose level, but you're still diabetic ketoacidosis. Sulfonylurea, sometimes you see it as well. Sulfonylureas are a medicine you can take. It makes your pancreas squeeze out more insulin. So some type 1s or type 2s that are transitioning to type 1 will be on it. Metformin has been a stable for type 2 for years. Don't see a lot of side effects with that really cause glucose changes. You'll see some increased liver issues with metformin. And all these things cause GI problems, right? And then the cool one that we got going now, the GLPs, Ozempic, Mounjaro, those drugs. So you may see a type 1 of those for weight loss or other reasons, and they may have a lower glucose, but still going to DKA. So if you're making that transport from hospital A to hospital B and you're seeing this and you're thinking DKA, but the glucose is low, you got to think, what are they on? Ask the patient those medications. If you're concerned about it, call med control. What you can do for this patient, you can't just give them insulin because you can make them hypoglycemic. So you got to start a dextrose drip and an insulin drip so the body can use what glucose they have. But we're getting way deep into the pathway now. So, what time we got? There's no way I'm going to get through all these. Stay here. I like vomit, one of my favorite body fluids. So I'll show this slide right here. Then we'll move on. So GI loss is another lab I didn't mention that we like to get. When you have diarrhea, lots of diarrhea, you lose one electrolyte, and it looks like this. Anybody know what that electrolyte might be? Magnesium, right? Like a magnum. That's good. All right, nobody smiled either. Great. So diarrhea, you get a low mag. So you always want to think about getting a mag level on anybody with GI complaints. Low mag leads to long QT syndrome. So if I got somebody that's got diarrhea, vomiting, right, and their mag is low, and I give them Zofran, all right, and they have a long QT, what happens to them? Yeah, pretty cool. Yeah. So you get to shock them and do things like that. So don't do that. All right. I think we're out of time. Chief, what questions we got? No questions? Everybody's asleep? That's great. Wonderful. All right. Questions from the audience? Yeah. Correct. Right. Yep. So they still don't have the body's cells do not have access to that glucose. Right. So they're peeing. Yes, sir. Yep. You still got the metabolic problem. The problem is you just don't have that lab value that makes you think, glucose is normal or low. Why is that? It's kind of weird. You can't be in diabetic ketoacidosis with normal glucose, and you can now because we can get your glucose down pretty good with mainstream healthcare, right? Yeah, yeah, yeah. So you have a patient that's known diabetic. They're puking. They look like crap. They're breathing 40 times a minute, but their sats are great. You throw capnography on them, and their capnography is low. You know they're in metabolic acidosis, right? So it doesn't matter what the glucose says at that point. They're going to get fluids from you. They're going to be treated at the hospital. We're going to maybe give them insulin, but add glucose to their treatment as well. Cool. Yes, sir. We should be. Yes, sir. Yep, yep, yep. The good thing in Birmingham, we're doing whole blood, which is a little bit better than just the component therapy. But yeah, if we're pushing a second unit of blood on somebody, we should have already given TXA, and we should be pushing an amp of calcium. Yes, sir. Yep, because calcium is needed for blood clotting, right? Other questions within reason? Oh, I thought I saw a hand. You got me so excited, sir. Oh, man. All right, that's all I got, Chief. Unless you got questions, we'll take a quick break.
All right, sounds good. We're going to take a quick break. Everybody that's listening online, the link to the attendance form is in the Q&A box.
Good morning, everyone. I'm Dr. Sullivan. I've spoken a few times, so I'm sure that most of the people who are listening have listened painfully at least to one of my lectures before. So good to talk to you guys again. As you know, I'm a UAB EMS fellow, so I'm glad to be here talking through cases in resuscitation with you guys. This morning, I unfortunately feel like I'm hungover, and I probably sound and look like it, but I didn't get to do any of the fun parts that lead to a hangover to get to feel this way. My little girl has got some virus, so I was like intermittent sleeping last night in increments of about 45 minutes. So all of the hangover, none of the fun. But We'll run through these cases. Some of them will overlap with what Dr. Ferguson was talking about. A few of his cases that he ran through, we'll talk about them a little bit more in detail, but it'll be good to kind of see him again because repetition, builds proficiency. So the objectives for today, I've got 5 clinical cases that we'll run through. We'll look at their kind of presenting symptoms, some key exam findings that I think can be helpful to lead you to a diagnosis, because at the end of the day, when you're in the field, you have none of the diagnostics, you have none of the information, you are obtaining it all from ground zero. And oftentimes you don't even have family to corroborate, you don't know these people, they don't have their face sheets sitting, but on the couch with them when you go and pick them up. So it's important to recognize physical exam findings, various physiologies of disease process. So we'll work through a few of those and recognizing those. We'll work through some of the pathophysiology. Nothing too boring, nothing to put anybody to sleep, but Lamont gave me this rubber ducky, so if I see any eyes closing, I'll hit it. We'll talk about pharmacology and a little bit of the why behind things that we give. And we'll talk about some frameworks that you can apply under stress, some things that you can fall back on, that I like to have handy whenever things get crazy. Financial disclosures, I don't have the fancy disclosure up there, but I wish. If any of you want to talk about some finances, I'm open to them. So the resuscitation mindset. So like I said, you'll never have all the data. You got to recognize who is sick, who is not sick, who is fixing to be sick. We'll talk about fixing perfusion, oxygenation, ventilation, fixing the physiology before you start intervening and doing procedures. We'll talk about having a plan. You want to have your A, B, C's in order before you enact plan A. You want to have something to go to whenever things get crazy, and you want to expect the unexpected. So we'll jump right in. So case number 1. And I found this, Seneca is one of my favorite Stoics that I like to read. He says, there are fires that burst forth from hidden places and shake the earth. Nature under pressure seeks an outlet. He was talking about volcanoes, but as does bad illness and patients and bad physiology. It wants to come out, and it will eventually, so you got to be ready for it. So the first case, you respond to a call. This is a 55-year-old male. They call it out for vomiting blood. So you show up, he's sitting on the couch, he's in like a dim, dingy, cluttered living room. Doesn't look like it's been cleaned in months to years. He's surrounded by evidence of massive hematemesis or a bunch of blood that he's thrown up. He's got a trash can sitting next to him that's full of it and has clots in it. He's got bright red blood around his mouth, and he's got crusted blood everywhere else. He's sort of intermittently conscious. He's not really able to respond to your questioning in any sensible manner. When you're not talking to him, he's just mumbling. He's gurgling on his respiratory secretions, and his mental status is worsening. You do note a history. This guy, he has a history of chronic alcoholism, and he has known liver disease. So we start looking over this guy. He looks terrible. He's pale, he's cold, he's diaphoretic. We start to see some of the things maybe that indicate some liver disease. His abdomen is big. It's very distended. He's pale. He has these funny looking blood vessels all over him. His hands and feet are beet red, and he looks like a highlighter. He's very, very yellow. You also notice that he's very tachypnic. He has shallow respirations, and he sounds like there is air or there is fluid that's bouncing around in his airway. He's obviously not protecting his airway very well. So you get your vital signs together. He's very tachycardic, upwards of the 140s. It's difficult to get a blood pressure, but you eventually get a manual, and you get it at like 80/40. You finally get a SAT, and it's 86%. You don't have a temperature. His GCS, you estimate somewhere in the ballpark of 10. So what's the first thing you would do in this situation? You've got this guy with evidence of liver disease, a bunch of blood that's coming from his mouth. He's altered. He's confused. He's gurgling. He's hypoxic. What are you guys thinking? Okay. Yeah. So you're not going to pretend he has capacity and just be like, I don't want none of this, and patient refuse transport. Yeah. You might want to pray as well. This man's hypotensive and looks terrible, and there's evidence of active hemorrhage. But yeah, that's exactly right. So let's talk about the physiology just a little bit before we talk about why you're right. What is this? Yeah, this is a variceal bleed. This is a guy with known liver disease that has likely esophageal varices. He's throwing up a ton of blood. That's what we're looking at here. So why does this happen? So they get a bunch of portal hypertension from blood backing up that leads to distension of these fragile veins that are at the very top of the stomach and the bottom of the esophagus. They get really high pressured and they're very thin walled, so they're at a very high risk of this happening. Anyone that has a known history of varices is at a very high risk of this. Anyone with cirrhosis, this is the feared complication. So these veins rupture when they get under, an acutely elevated stress, and massive hemorrhage happens into the distal esophagus and the stomach, and where that comes is out the top. If you had a very slow bleed, sometimes you see that in melanotic stools and things like that. But in these cases, usually when you have a big variceal rupture, this is a massive upper GI bleed. So what you get is a bunch of aspiration. Usually these patients, like when they get unstable, they get altered. They may already be altered from like hepatic encephalopathy, which we talked about earlier, from an elevated ammonia level. But these guys have bad livers, and therefore they do not make clotting factors very well. Their synthetic function of their liver is typically decreased at this point, so they have an even harder time stopping the bleed once it starts. Just because of its position in the GI tract with the acidity of the stomach, it's already hard for a normal person to clot there. And these guys pretty much are at the short end of the stick as far as their coagulability goes. So what you get is a bunch of early airway contamination, a bunch of aspiration risk, and not only do you get hemodynamic compromise from the bleeding, you risk a hypoxic arrest as well. So which comes first in this? Airway, physiology, how do we go about this? And as we said, we're going to address his position. We're going to address suctioning the patient. We're going to do those things before we start doing other things. This patient is dying and he is having a respiratory issue, but he's not necessarily dying from a top priority list of a lack of an ET tube. So if you took this patient and you sat him up, whatever, you pushed a bunch of meds and went to intubate him because you're like, he's in respiratory distress, this patient's going to die. He's unstable, he's very hypotensive, and only getting more hypotensive. So you want to make this guy intubatable. You want to sit him up, you want to get him suctioned out, you want to get him resuscitated from a pre-oxygenation standpoint as well as from a volume standpoint. Now, what do you have available? Do you have whole blood products with you? That's the best thing. That's what we're going to do in the hospital for this guy is Belmont a couple of units into him. But you may not have that, so we volume resuscitate as best we can. But our goal with all of this is to restore the minimal safe physiology to intervene on this guy. And how do we do that? That's volume resuscitation and then optimizing his airway to get him pre-oxygenated before the tube. So our strategy here, priorities, as we said, is getting him set up, trying to prevent immediate respiratory compromise, trying to keep him from dying this very second. We want 2 large bore IVs. We want them as big as we can get them, as fast as we can get them. A lot of times these guys are very volume down, so IV access is not super easy. Certainly not straightforward. If you can't get an IV expeditiously, do not hesitate to drill these guys. If you can get an IV, you want it as proximal as possible and in the largest type vein that you can get. And as we said, like a fluid resuscitation strategy, not everybody has access to whole blood products or blood products at all. Sometimes we're in rural departments that don't have this available. So volume resuscitation as best we can. But here in Birmingham, fortunately, we have whole blood that's typically available, and hopefully we've got EMS4 en route to these cases when we recognize them as massive GI bleeds. There is some thought behind the permissive hypotension approach. So as we said, these are high pressure systems where they're bleeding into their GI tract. 70s over 40s is not permissive hypotension. That's crossing the line more into a we got to intervene on this now. But from a permissive hypotension standpoint, somewhere around 90 or just north of that is okay if you can maintain that. Current evidence does support that kind of restrictive fluid resuscitation, especially if you're not dealing with blood products, may be favorable for these guys, as so long as they are not critically unstable or have like a MAP below 65 or a systolic below 90. And that's because if we're giving fluids, we can worsen acidosis, we can worsen their already poor coagulopathy status by giving them a bunch of crystalloid fluids. But if you have blood handy and there's obvious evidence of all this blood loss, that's where we want to go with these guys. So other interventions. Blood is what they need because blood is what they're losing, but there are other things that we can do as well. So TXA. I want to say back in the 20-teens, maybe as late as 2020, there was a trial that came out that was like, maybe TXA doesn't necessarily help these guys, and maybe it increases risk of thromboembolic events. In 2024, there was a meta-analysis that came out that did show conclusive evidence that TXA does oftentimes prevent rebleeding in these patients, and there's no evidence that it increases the risk of forming a blood clot where you don't want it. So TXA 2 grams IV is certainly indicated for these patients. Apologies. Other things that we do in the hospital that you may not necessarily have access to, some of these you will. Sometimes you have blood products handy. Obviously, that's the last one we've talked about it. You'll have antiemetics on board. You'll have Zofran, maybe have Reglan. Reglan has some theoretic benefit of causing an increase in gastric motility and can possibly push some of that blood down the track and kind of help you from an airway standpoint. But you know, that's going to be agency dependent on whether or not you have Reglan available. Everyone should have Zofran. Other things we do in the hospital, we give them octreotide. So we'll give them a bolus and drip of octreotide. And this is more relevant to folks who are transporting from the lecture before, like a critical care transport service. They may be on an octreotide drip whenever they leave the hospital going to a larger center where GI is available. So octreotide is one of the pancreatic hormones that works in the GI tract. But what it specifically does in this situation is it causes what's called splanchnic vasoconstriction. So basically what that means is it decreases the pressure and decreases the blood flow inside of that area specific to where this blood is coming from. So theoretically, there's a benefit of vasoconstriction there that reduces the blood flow to those vessels and therefore reduces the amount of bleeding. We give antibiotics to these folks specifically to prevent infection, whether that's bacterial peritonitis in these patients with large volume ascites, or to prevent any type of chest or thorax infection if there's any kind of rupture or anything of that nature. So we give them empiric antibiotics. We give them proton pump inhibitors, so like Protonix, pantoprazole, and things like that. The reason behind that is, as I mentioned earlier, the stomach is a very acidic environment, right? That's where all your gastric acid and things like that are coming from. One of the lethal triad in trauma is coagulopathy and acidosis. So the thought behind a proton pump inhibitor, so we usually give them 80 of IV Protonix and then put them on a drip, is that will decrease or increase your pH. It will decrease the acid excretion in the stomach and therefore promote clotting of the blood vessels there. Because in the GI tract, because of the acidity, it decreases the ability to clot. So we're trying to raise the pH there and increase their ability to form a blood clot. So those are the things that kind of the standard of emergency care there is what we kind of go with. So at the end of the day, so this guy, he was unstable. He's also obviously aspirated and respiratory compromised. So he's got to be intubated. And once we've gotten him stabilized, gotten him to where we are prepared to intubate this guy, his blood pressure's better, he's a little bit better pre-oxygenated. I would recommend that you have at least 2 suction catheters set up. I like Decantos just because of the amount that they're able to suction and kind of the way they're structured anatomically. But if you just have the regular Yonkers, that's totally fine. But I'd like for you to have two. One, because if you get a clot jammed up in there and you lose your suction, you're going to have a bad day intubating these guys with an esophagus full of blood, and your picture might look like the one on the top. You'll also want to position them, as we talked about. You'll want to intubate these folks with a little bit more of a positive angle for you. In the setting of video scopes, this is not as much of a problem as it would be as if you're trying to direct intubate these guys. You can stand a little bit more of a little less ideal position to get that, to use gravity to your advantage, right? To prop them up and let the blood kind of pool down below instead of coming up and getting in the mouth and in the back of the throat where you're trying to look. If you're going to bag these guys, just be aware of your breaths that you're delivering to them. If you feel their stomach full of air, and then lay these folks back, take away their muscle tone, expect that air to kind of push a lot more of that blood up. So be aware of gastric insufflation from over vigorous ventilation. And don't push your meds, obviously, until you have all of these things in place. You'll want to have plan A, B, and C all set up there before you ever consider giving them a sedative or a paralytic. Have your backup airway planned as well. So that's kind of the upper GI bleed standpoint. The basics from this is identifying the physiology, identifying the problems that are going on other than the GI bleed, like the hypoxic respiratory collapse, having all your equipment available, knowing your medications and why we're giving them. Second case, 68-year-old guy found by a family member unresponsive at home. He was pulseless on EMS arrival. They do have an organized rhythm somewhere around 30 beats per minute. His lungs are wet with ventilations. You can hear crackles, decreased at the bases, and CPR is currently underway. His extremities are cool. They've already given him some epinephrine, but nothing's changed. This is kind of where things start to be given away. There was no family available for a history taking. You don't know this guy. So we'll start with our vitals. So on the monitor, he's got an organized bradycardic rhythm, wide complex at about 30. Obviously, he doesn't have a pulse. Obviously, he's apneic and BVM respirations are going on. His no measurable blood pressure, obviously, is not connected to end tidal yet. And we don't have a SAT. So on exam, he's unresponsive, he's pulseless, and he cooled to the touch. We talked about his lung sounds. He has jugular venous distension, and you notice this big worm-looking thing on his right bicep. Looks like a fistula. So we got a guy, cardiac arrest, bradycardic, slow, dialysis fistula. What are we thinking? Yeah, hyperkalemia. Exactly. Calcium's the answer. So this is kind of what you're looking at. Why does this happen? So this guy missed dialysis. Potassium is built up, and now he's arrested from it. So why does this happen? So potassium in the heart, it makes your resting potential less negative, right? So your cardiac cells remain in kind of a depolarized state. It also inhibits sodium channels, so you get a widened QRS. All of this to say it like decreases the heart's ability to respond to the electrical conduction in the heart. So you wind up still with electrical activity on the monitor. You're just not getting anything out of the heart because the muscles are kind of depolarized. They're not able to respond. They're not able to make the ion shifts that they need to in order to contract. So you get a PEA arrest. He's also missed dialysis, so he's probably a little more acidotic. He's probably got a whole lot of metabolic derangements going on, so he's doing nothing to help himself. And that's another reason why he's not responding to epi. On the right, you can kind of see the progression of what you would see in your PQRST as hyperkalemia progresses. Up at the top, a pretty normal morphology QRS. And as we go down, kind of stepwise changes that you'll start to see is first, you'll see the T wave change. you'll start to see it kind of getting taller than your QRS, really start to jump out on EKG to you. As we go along, we maintain our elevated T waves, but sometimes they'll start to shorten and widen out a little bit, but you'll start to see your QRS start to prolong. And now we're getting into more serious hyperkalemia. And as we progress on down, then we get total loss of normal morphology. Everything is so spread out, it looks like a sine wave. So you kind of lose that clear QRST. You start to get this weird kind of funny wave shape thing. And if you're there, that guy's going to arrest any minute, if not already. So these are some classic EKGs that you might see. On the left, you're already starting to get some QRS prolongation, but you can really see some pronounced T waves there. And on the right, kind of same situation. You're starting to see that QRS really start to widen out. So to kind of break this down into basic algorithms, so we're confirming PEA and we have a high-risk history in this patient. He's got a dialysis fistula, or you're at a place, or you're at the dialysis center where someone has showed up, or their family member is present and say he hadn't gone to dialysis in 2 weeks. So we're starting high-quality CPR. We're doing all those things. We're doing our respirations. We're maintaining our standard of care for cardiac arrest, but we're aware that this patient is at extremely high risk for hyperkalemia, so we're giving calcium early. Calcium chloride or gluconate, we're giving those right away. So that's a full gram of calcium chloride or calcium gluconate via IV, IO, whatever you have. Adjuncts to that, sodium bicarb. 2 ways that works. One, it will increase your pH and kind of optimize you from a standpoint of being able to help all your kind of electrolyte channels function more properly in the heart based on its environment with the pH. And it also is a potassium shifter as well, so it can kind of assist you in shifting potassium into cells. We also give albuterol in severe hyperkalemia, upwards of 5 to 10 milligrams inhaled if able. If you're ventilating a patient, we can obviously give that through the ET tube, or if you have a patient on BiPAP or something like that, we can give it through that as well. But a lot of times we will give a ton of albuterol in this as well because it does take a lot to get in effect. But similar deal, it is a shifter. It does not fix the problem. Ultimately, the answer here is to get this patient to a facility where they at least have the ability to give insulin, and monitor the patient more closely with labs, continuous cardiac monitoring, or to a center like UAB that is dialysis capable, because ultimately that's going to be the answer here is dialysis. So essentially, to wrap that up, when you have a patient in PEA arrest or any kind of slow bradycardic wide complex arrhythmia and they have the risk factors, or even if they don't, if you see a PEA arrest, you have to consider hyperkalemia, particularly if you've had any kind of indication that this patient might have some sort of renal insult or have been on dialysis in the past. So case number 3. So this one is a 40-year-old female in severe respiratory distress. Family is here, and they say she has a history of asthma, and she's had attacks sometimes, but she's never had anything really like this. She's sitting in the kitchen. She's tripoding. She is sweaty. She looks terrible. She can't speak more than a single word. She's using her accessory muscles. She looks like she's in the fight of her life because she is. So we move on to kind of our exam and vitals. So what you're seeing is an afebrile patient who's very tachycardic in obvious respiratory distress with upwards of 40 respirations or more per minute. She's hypertensive because of her sympathetic tone. Her oxygen saturation is like 84% on room air. They've got an end tidal on her. She's upwards 40s, 50s, 60s on her end tidal. Obviously, she's diaphoretic. She's tripoding. She's visibly anxious. She's unable to speak anything more than a word or two. Respiratory distress, tachycardic, cool and moist. She's got JVD, and we are not able to get great waveforms. On her lung sounds, they are very diminished. This is an asthma exacerbation, obviously. We have the history here. This is a patient that's obviously in respiratory distress. So what are we going to do about it? So we'll talk through what an asthma exacerbation actually is, and that way we can talk through the medications and interventions a little more informed. So this is essentially an obstructive lung disease where patients will get severe bronchospasm, mucosal edema, they get a lot of inflammation, mucus plugging, and so they get severely narrowed airways. And behind those airways, they get air trapping. And so what that does is not only does it decrease their oxygenation ability, it decreases their ability to get CO2 out. So they get what's called air trapping. That's why early in an exacerbation, a lot of times we'll hear very musical airways, right? You hear a ton of wheezing. This is very obvious, but in a late stage asthma exacerbation, the chest may be very silent. And the reason for that is because they are so constricted in their airways. They're trapping all of this air behind. And so the vast majority of their lungs are not moving air at all. So when you put your stethoscope on their back in the lower fields, you're not hearing anything. It sounds like you're listening to like a thigh muscle or something or a brick wall. You're not hearing anything. And that's a problem. And that should indicate to you that this patient is likely peri-arrest. So that should definitely get your ears perked up a little bit. So ultimately consider this an inflammatory obstructive airway disease where these patients have a ton of fluids, a ton of secretions, and a ton of inflammation in their airway, and they're trapping air behind those airways to where they can't move oxygen down, they can't ventilate and get the CO2 out. Similarly, a COPD exacerbation is also an obstructive lung disease and works much in the same way, except for this is more of a chronic, long-standing airway inflammation disease rather than like an acute exacerbation. These folks just have poor ventilation because they have loss of elastic recoil, they have destruction down in the bottom in their small airways and their alveoli, but at the end of the day, they get into the same type exacerbations where they get a bunch of acute inflammation, they get all of those secretions and all those things. So we treat these two in much the same way, except for a few caveats towards the end. But much of the interventions for these two disease processes are very similar. And especially from our standpoint, they will mostly be the same in the pre-hospital setting. So airway inflammation. So obviously this is where we get our acute hypersensitivity type reactions that trigger a bunch of airway edema, mucosal swelling, mucosal hypersecretion. As those swell and as those get blocked up from those secretions, that's when we get the air trapping. We get bronchospasm, so the smooth muscle around the airways start to contract and they start to clamp down. And so in the same way, they block everything behind it. You can't move air to where you have your cells that actually exchange gas. Mucus plugging, obviously airflow obstruction and a ventilation mismatch. Beta receptor fatigue. So the beta receptors are what cause your smooth muscle relaxation when they're activated. As you burn those up and as you utilize those trying to compensate for this, you wind up down-regulating these receptors or they stop responding as well, the ones that you do have available. So you lose that intrinsic ability to relax that smooth muscle as well. So you get kind of stuck. And you can get stuck despite beta agonist therapy as well. And so your resultant physiology is that you get an increasing CO2, so you get a worsening respiratory acidosis, so your pH falls, it increases your work of breathing, you get tired, the patient fatigues, they stop moving air well, and then you have a full respiratory arrest. And then you have this fancy slide out on the side that kind of show where these things are working and what all this stuff is. It's a little fancy. So knowing those things on a basic level, the pharmacology. So what are we doing about this? So obviously the first line in our pre-hospital intervention is going to be albuterol. What is it? It is a beta agonist. And all that smooth muscle that has beta receptors on it, it goes and sits on those beta receptors and it causes smooth muscle relaxation. So in theory, that should open up the airways, give you a little bit less airway resistance, and therefore you can move air easier, you can move air deeper, you get more gas exchange. Ipratropium is a lot of times given initially up front as a duoneb. You usually give these together. And in kind of the same way, this works from a different pathway, but same result. You get smooth muscle relaxation, you get a decrease in bronchoconstriction that improves your airflow. So a lot of times, instead of just giving albuterol, we're giving a first-line duoneb, which is totally appropriate. But do know that redosing a duoneb is not of a whole lot of, what am I trying to say? Not of a whole lot of use, because an appropriate dose of ipratropium usually has an effective window of about 4 to 6 hours. So stacking more on top of that isn't necessarily going to do anything for you. So that's something that you can kind of put out after you give an appropriate dose of ipratropium up front. You're not wrong to give more duonebs, but just know that any extra effort that goes into redosing ipratropium in the acute setting is probably not doing a whole lot for you. So that's one less thing you have to worry about. When you redose, I would redose albuterol. Next up would be steroids, would be our most common. Most of the time, it's going to be like 125 milligrams of Solu-Medrol, or 10 milligrams of dexamethasone, or in pediatrics, it's like 0.6 mg per kg. And that actually works in an interesting way. Like, the general sense is that steroids decrease inflammation. They don't necessarily do it fast. It's more of a thing that happens over the course of hours. But giving steroids actually, which I think is pretty cool, actually modifies genes. It's actually like almost like kind of a gene therapy. And what it does is it upregulates anti-inflammatory proteins in the lungs that can help decrease that airway inflammation over the long term. So the advantage to you guys giving steroids is not necessarily to fix the patient right now, but it initiates that anti-inflammatory response earlier, and therefore can get the patient out of this exacerbation in a much more reliable sense faster. So there's a big advantage there for recognizing this and giving it early. Mag sulfate, 2 grams IV, typically over like 15 to 30 minutes, depending on your protocols. Interestingly, magnesium can cause some smooth muscle relaxation, but it can also theoretically upregulate your beta-2 receptors. As I said, like, as you go on in this like prolonged inflammatory state, you get that downregulation, and there's plausible evidence that mag sulfate will upregulate the beta agonist or beta receptors in that smooth muscle, and therefore make you more responsive to albuterol therapy. So unless the patient is hypotensive, because mag can sometimes cause a little bit of hypotension, magnesium sulfate is a good place to go. Epi can be used in these situations if you've got nothing else. Like, if you're giving all these medications, you're not getting a response. You can give IM Epi in these cases for like really severe life-threatening asthma that's persistent despite your best efforts. It can also hit beta receptors as well and cause some vasoconstriction as well, which can kind of decrease airway edema. So it's one that is a little bit more of a last resort towards the end of your kind of pathway here, but it is something that can certainly help. And kind of down here at the bottom, again, a real fancy, noisy slide, but a lot of the specific locations that these medications act on are there kind of for you to review. So CPAP and BiPAP in these situations, if we're getting to this point, like, this is usually a pretty ominous deal, particularly with intubation. I think early CPAP or BiPAP can really help in these situations. And the reason for that is when a patient is fighting for their life, trying to breathe, obviously they're tired. Particularly if this is a child or an older person, they can get fatigued really quickly, and they can fall off a cliff really quickly because they have no reserve. And once they start to go out and they can't pull the air in even to the few airways that they have open, CPAP and BiPAP can kind of splint those airways open and promote the best ventilation that you can get. So what airways that you do have access to, it can kind of increase those, and a lot of times can help you out. The caveat to all of these things is obviously with non-invasive and invasive with intubation, this is going to increase your intrathoracic pressure. So with asthma and you get a bunch of air trapping, you can have at baseline an increased intrathoracic pressure. So you can put yourself at risk for barotrauma, and you can also put yourself at risk for hypotension because of the intrathoracic pressure. I would say for intubation, this is like a last resort, right? This is when a patient is totally exhausted, when a patient is no longer providing any type of adequate respiration for themselves. This is what we go to. In a hypoxic patient in respiratory distress, it makes sense to want to put these people on a ventilator, run the rate up, and really aggressively ventilate them. But that's not actually the way you want to go in these patients with asthma. In COPD, this can be a little more reasonable because they're not so much blocked off for air trapping. They're typically moving air a little bit better. So a lot of times having their rate somewhere in the normal to elevated range can help you get faster gas exchange. But in asthma, if they are trapping a bunch of air and the problem is that you can't really get air down into the distal airways, you can really increase their intrathoracic pressure through breath stacking. And that's when it becomes more important to have that ventilator training, to know, to watch your waveforms to where you can see breath stacking to where you're putting air in, but before you deliver the next breath, you're not necessarily getting it all out. So for these patients that we intubate, we typically do a very slow respiratory rate, somewhere around 6 to 8, and we give them a very long expiratory phase. So we get the air in and we give them a long time to get that air out because it takes a lot to travel out. In a restrictive lung disease, it's difficulty getting air in. And in obstructive air disease, like we have with asthma and COPD, a lot of times the problem is actually getting the air out. So increasing their expiratory phase and decreasing the respiratory rate can be really advantageous in these situations. So the vicious cycle of asthma, this is what we're fighting against, right? So they start to get inflammation. They start to increase their respiratory rate. More air gets trapped, more secretions, more obstruction, more inflammation, more sympathetic tone. They get anxious. They breathe harder. They start taking more shallow breaths. They're not exhaling enough. They air trap more. And you get into this cycle, right, of like hyperinflation, gas trapping, hypoxia, rising CO2, acidosis, decreasing oxygen rates, decreasing mental status. And you get in this spiral until you ultimately collapse into a respiratory arrest. And so ultimately, that's what we're fighting against, right? Is at some point in this spiral, we show up and we try to intervene. So this is where we try to stop the process. So case number 4, a little pediatrics. A 3-year-old boy lying in his mother's lap. He's limp. He's barely responsive. He hasn't been eating or drinking well per mom. His lips are dry and cracked. His extremities are cool. He doesn't have great cap refill. You can stimulate him. He opens his eyes a bit, but he doesn't do much, and he kind of goes back to sleep. He's breathing fast. His respirations are very shallow. He looks unwell. You get your initial blood pressure, but fails to register. You can't get one. Got his heart rate about 190. You're worried about this kid. So you do your exam. He's somnolent. There's minimal responses. He'll wake up. He'll look at you, but not doing much else. He's pale. He's cool. He's mottled. He has weak distal pulses. His capillary refill is prolonged. His lips are dry and cracked. His skin turgor is very delayed. He's very tachypnic. Increased work of breathing. He's not moving very well either. You note a few wheezes, and he's a little bit irritable. His oxygen saturation on room air is 92%. He's febrile, can't get a blood pressure. He's breathing fast and shallow, and he's very tachycardic. What do you think may be going on with this kid? Yeah. Ultimately, he's probably volume depleted for one reason or another. So this kid is septic. But kids, so they can show up this way from a bacterial infection, whether that's like a pneumonia, a UTI, if they're predisposed to it, or if they have some kind of genetic condition that predisposes them to bacterial infections, if they're immune suppressed and things like that. But kids can also show up like this with bronchiolitis, with just basic respiratory infections. They can get behind on their intake. They can get bad dehydrated and get in that spiral. But it's important to recognize, like you're saying, that this kid is dehydrated. This kid is volume down, that they're in shock, and they're technically in septic shock. So thinking about kids, we think through all of our kind of reasons to have shock, right? Kids can get sick for a lot of different reasons. But in pediatric shock, kids hold on for a long time. Kids compensate well until they don't. And when they fall off a cliff, they really fall. So the first 5 to 10 minutes of your resuscitation is really key. And in the same way as if you had a hemorrhagic shock patient, in these patients, you want to prioritize getting access quickly. If you've noted that this patient is in shock for whatever reason and they appear volume depleted, I want you to work on access. If you can't get an expeditious IV, do not be afraid to drill an IO on a kid. I would rather drill the kid, the a barbaric appearing procedure for the parents to see, whatever. I would rather that kid get volume and get rehydrated and get them out of shock, or at least on the way, rather than mess around getting an IV. You always want to check glucose on kids, particularly in a bacterial infection. They are very prone to becoming hypoglycemic, and that can be an easy reason that they are altered, and you can fix their mental status pretty quickly that way. You want to get them on oxygen, and you'll want to get them warm. A lot of times kids that are septic will present hypothermic rather than hyperthermic. This kid is already warm, so that point is not necessarily applicable in this case, but a lot of times they'll show up 95, 96 degrees and have a bad pneumonia or something along those lines. But when we're thinking about kids and types of shock in children, we think about septic shock, obviously, anaphylactic, neurogenic shock if they suffered some kind of trauma, particularly like non-accidental trauma. People don't know what happened to them. They just showed up this way. This is something that we think about as well. The cardiogenic shock, heart failure, some undiagnosed septal defect that they've reversed a shunt. Do they have some other congenital cardiac defect? Do they have some kind of cardiomyopathy from a recent illness? They have Kawasaki disease, MIS-C that they saw a lot during COVID and other viral illnesses. They have tamponade, pericarditis, a pneumothorax for whatever reason. Are they bleeding, or have they just lost a bunch of volume from either sepsis or GI losses? So by the numbers, the most common causes of shock in kids, the most common one is septic. Hypovolemic a lot of times can fall under that umbrella too, because typically a patient who is septic has multiple forms of shock, but specifically they're volume depleted too. So that makes up pretty much the majority of septic shock cases. Then you have your kind of distributive shock, cardiogenic from undiagnosed or underlying cardiac defects, or an obstructive shock, which is a little more on the rare side. But I like that little schematic to kind of walk you through a lot of the reasons that kids get shocky. So in sepsis with kids, it's so important that we recognize this early. Obviously, this kid was a little more straightforward in being febrile and in shock, so we can kind of lock on this earlier. Our kid was tachycardic, and he had evidence of poor perfusion, and he was altered as well, which leads us to recognize that he's hypovolemic and is in need of some volume. So immediate actions, as stated earlier, oxygen warming the patient if they're hypothermic. You'll want to get access quickly, IV or IO. After we've checked our glucose, now it's time to consider volume resuscitating this kid. Typically for children in sepsis, it's somewhere like 20 to 30 cc per kg boluses. Per the Alabama protocols, it's a 20. So if you take a quick weight from the kid or use your Broslow tape to get a gross estimation, you can get a rapid estimation of their kind of ideal body weight in kilograms and go off of that. I recommend, and I put it in anytime I talk about pediatrics in a talk, I mention the app PediStat. It's like $5 a year, and it's worth every penny. If the parents are like, I don't know how much he weighs, whatever, he's like, but you have a sense of how old he is, you can plug it in by specific months, and it will spit you out numbers. And so it will tell you not only what the size of your fluid bolus needs to be, but it'll also give you the weight-based dosing for all of the other things that are going on, whether that's cardiac arrest, push-dose pressors, infusions, and things like that. So I think PD Stat should probably send me a check or something, because I'm sure that I've sent a lot of people their way. So maybe they can be my first financial disclosure. But I mention that every time because I've found it in a very sick pediatric resuscitation to be super helpful. But that can be your Broselow tape. That can be whatever resource that's going to help offload some of your cognitive process in this, because a sick kid is extremely stressful. It's just different than a sick adult. Obviously because it's a kid, but I think that may be a little less recognized, that things are just harder when they're kids. Even if you know the information cold, it's hard to remember these weight-based doses. So I would recommend that you have some kind of resource handy to help you cognitively offload some of those things. But anyway, so if this kid is still shocky, a lot of times we'll start an ideally epinephrine infusion. Kids unfortunately don't have as much evidence-based kind of algorithms. You know, we typically start, if we're starting a pressor for septic shock, with like a levo, vaso, and then epi. They don't really have that. So they kind of, the way it was put to me one time, that, you know, for what it's worth, they said they treat the physiology in front of them. But for us, I think epinephrine is a safe place to go if that's in your protocols to start for kids. An infusion dose for them is somewhere around like 0.1 to 1 mic per kg per minute. Again, that's where I would recommend you have some resources to help you get an appropriate dose for a kid, so that way you don't have to remember these things when you go out in the field. We have some other pressors that are there listed. Not as common to start kids on this out in the field, but push dose epinephrine can be very helpful in that situation. And you're looking at about 1 mic per kg in a push dose every 3 to 5 minutes as needed. That's one that I like to have handy. So transporting these kids early is really the answer here. There are things that you can intervene on, but ultimately this kid's going to need all the resources of either the closest available hospital or preferably a pediatric center where they specialize in this kind of thing. So the key features here: the patient's going to be febrile or hypothermic. They're typically lethargic. The parents will report poor PO intake or poor urinary output over a couple of days. Tachycardia out of proportion to their fever. So we're talking like extreme sinus tachycardia. Delayed capillary refill, cool mottled extremities, like they look gray. They obviously look terrible. And then a real floppy, lethargic, weak baby with poor tone when you pick them up. So our priorities in the field is, if they need warming, warm them. If they need oxygen, giving them oxygen, and getting access and starting some resuscitation if they are in shock. Again, per our state protocols, that's a 20 cc per kg bolus is a safe place to start. So having a ballpark weight on these kids, very advantageous, and then calculating an appropriate dose. Early epinephrine infusion, if your agency allows that, and knowing your dosage there. RSI, typically with kids, you can put in an OPA or an MPA and bag them pretty adequately. But if for whatever reason you're having difficulties there, RSI is kind of a different beast. That should be covered in a separate lecture for pediatrics, so we won't jump into that here. But again, why this matters: pediatric sepsis is going to account for, probably out of all of them, it's your largest contributor to pediatric shock. So being able to recognize this early and intervene appropriately can significantly improve outcomes and really help these kids, because what happens on the front end, the faster interventions happen for them, the better. So the last case, this one's a little bit easier. We'll run through it pretty quick since we're right at the end. So a 27-year-old, high-speed motorcycle accident. He looks like crap. He's obviously visually in shock. You notice that he has an asymmetric chest rise. He's got a tense abdomen. He's breathing funny, and then he starts to get altered. So he's very tachycardic, tachypnic, hypoxic, hypotensive. He looks like he's in shock, so he looks all the parts. So he's altered and confused. You've noticed an asymmetric chest rise. He has distended neck veins. He's got a bunch of flank tenderness. He's got a bunch of bruising and a tense abdomen. He is bleeding actively. He has a weak radial pulse, decrease, cap refill, all the signs and symptoms of hemorrhagic shock. What do you think is the most appropriate intervention in this case most expeditiously? In a patient with an asymmetric chest rise, maybe decompressed breath sounds. Yeah. So we need to pop his chest. Yeah. So if you had a penetrating chest trauma, yes, slapping a 3-way over the top of it. But ultimately, you want to pop these guys' chests. So this guy's got two things going on. He's got hemorrhagic shock and tension pneumothorax. So to kind of run through the tension pneumo, that's when air gets between the lung and the chest wall. It starts to expand, increases your intrathoracic pressure, compresses your heart, and decreases its ability to pump blood out and get blood back into the heart. So you go into shock and can rapidly progress into PEA arrest. Down below is a chest X-ray of a very, very large pneumothorax. He's not necessarily shifted over too much, so that guy may or may not be an actual tamponade or in a tension pneumo, but he's obviously got a big one there, and that's kind of what we look for in the trauma bay. But he's also got hemorrhagic shock, so he's got a bunch of blood loss. So he's losing the preload that he desperately needs to pump through a tension pneumo. So he's going to fall off the cliff even faster than most. These patients will present hypotensive, altered, ultimately descending into cardiac arrest. So, talked about decompression. Where do we do it? Traditional site, second intercostal space in the midclavicular line. I palpate the clavicle. I go down one more and find a rib space, and the one just below that is typically my second intercostal space. If the patient is lying supine, typically by the way that gravity behaves, air is light and the solid stuff falls below, you're typically pretty safe to pop their chest there. I prefer, just in my practice, just because this is where I put in chest tubes, the mid-axillary line. Sometimes when you have a normal shaped human with not a lot of extra tissue, you can find the kind of triangle in between the pec muscle, the lat, where you can get in the chest with pretty minimal hard or soft tissue, but harder material or fat to go through, so you get straight down to the chest wall. This is straight down from the nipple line, typically in the fourth or fifth intercostal space, and the anterior axillary line is where I like it. We try to stick these things over the top of the rib, just because there's a neurovascular bundle. You can poke through an artery and cause yourself more problems. But with the needle decompression, that's typically not as much of an issue as it is when you're putting in a chest tube, but it's something that you want to be aware of, and you want to shoot for the top of the rib rather than the bottom. These things fail, so once you put one of these in, you want to have them on cardiac monitoring, and you want to be monitoring their vitals or signs of a reaccumulation or failure of that catheter. So blood, what are they losing? They're losing blood. Once you've popped their chest, they're still in shock. You're confident that the lungs are re-expanded. Now it's time to refill the tank, right? So all of the evidence at this point from our military data, and especially because that's where the most robust evidence is right now, is that blood is better, right? And it makes sense for someone like me who doesn't do a whole lot of academic stuff, that's kind of not a big test-taking guy. It makes sense that someone that's losing blood needs blood, right? Evidence for civilian trauma is coming out, not as robust in the setting of like being 5 minutes from a trauma center, but at the end of the day, this is where the pre-hospital trauma scene is going. We're giving whole blood in Birmingham, not only because it is blood and what they need, but whole blood in particular contains all the clotting factors and things that they need to form a blood clot and stop bleeding on their own. But from our standpoint, when we're talking about a patient in hemorrhagic shock, we're looking for all places that they could be bleeding. So if that's from the extremities, we're putting on tourniquets. If it's in the crevices or up in the axilla and things like that, we're packing wounds where we can't get good compression or we can't get a good tourniquet on, and we're wound packing and putting pressure on. Pelvic binders are another kind of controversial thing. If you think that there's a wide open destroyed pelvis, like put one on. If you don't, that's not necessarily the wrong answer either. But I would say that in a pelvis that's like wrecked, I would err on the side of putting one on. Crystalloid, if you don't have anything else, it's obvious that this can cause more coagulopathy and cause more acidosis and cause them to clot less. But if it's all you got, it's all you got. And if a patient is in severe shock, give what you have. And again, we talked about permissive hypotension for the upper GI bleed before. We don't necessarily have to get back into that here. But at the end of the day, we are going to blood products, and that's where the future lies for pre-hospital trauma. So in this patient, he's got both. He needs his chest popped. He needs continuous monitoring from that standpoint from reaccumulation, and he needs blood. Unfortunately, we have the ability to give it here in Birmingham. So all that being said, what questions do you have about any of these cases? I know that was a lot of words. These are hour-long talks, so there's a lot of information that comes out. I'm happy to try to clear up anything that may be unclear, and then we have smarter doctors in the back who can correct my mistakes. I figured that both of you combined might be all right. Yeah. Yeah, so the question is, in a patient with asthma that's air trapping and already has increased intrathoracic pressure, is adding something like CPAP or BiPAP going to run the risk of causing more hypotension because of the increased pressure? And the answer is yes. That's the thought behind not intervening with positive pressure until we absolutely have to. When we talk about, or when I put patients on like BiPAP or something in the emergency department for asthma, it's because this patient has expended their energy resources. They are tired. Even if they had the airways to put the air in, they couldn't get it in there themselves. And so this is to assist ventilations as kind of a last ditch effort to try to open up and try to help them with their oxygenation and with their respiratory effort. There are things you can do. You can run fluids behind it, especially if the patient is not volume overloaded. If this is just a strictly asthma, you can optimize their preload from that standpoint. You can use push dose pressors and things like that. But ultimately, that is a concern, and you run the risk of hypotension, and that's why it's more of like a risk-benefit thing that you have to decide as the clinician that's taking care of them. Is this patient in a place where they can tolerate it? Like, is their blood pressure 150 over 80, or is their pressure 80 over 40? If the patient's got a blood pressure of 80 over 40, I've got to be aware that if I go to that and I haven't intervened on the blood pressure, that I might cause them to arrest, or I might cause them to become worse with that pressure. So yes, that is a risk, as is the barotrauma and causing like pneumothorax. I'd say when I did my pediatric ICU rotation, that was not an uncommon thing for a kid that was intubated to leave the department with both lungs up and then show up with lungs down, not because of anything that anyone did in transport, but because they got tubed, an hour, 45 minutes away from Children's. They were breath stacking the whole time, and then they were sent out and popped the lung. But yeah, it is a problem. And it's something that you kind of have to make an assessment of, like, is this patient in a place that they're going to be able to tolerate that? Is there anything I can do to support their hemodynamic status and increase their preload and kind of combat that increase in pressure in there? And does this patient, is this patient in a place where they need that and that risk is worth it? Yeah, so if you're putting them on positive pressure ventilation because of hypoxia and because they're not moving air, then yes, that IM epi should be somewhere around this. You shouldn't go straight from like Duanebs and albuterol straight to BiPAP or CPAP. Like, you should be progressing down your algorithm of what you can do and your interventions that you have at your disposal before we say, like, we're just going to put them on CPAP now and hope for the best.
I would say too that sometimes CPAP with albuterol seems to do the trick.
Yeah, because you, like we said, we stent those airways open so we can deliver that medication deeper into the airways and theoretically open up more airways, and then ongoing, we stent things open, we open them up, we deliver medicines further down into the lungs, because albuterol that doesn't make it through half of the airways doesn't help those. It only helps what it gets to. Yeah, like deliver. Yeah.
So on the issue of albuterol, Dr. Sullivan, we do have one question that came in. Would albuterol in the ET tube in the hyperkalemic cardiac arrest patient be acceptable, or an exception? And I think what they're asking there is I think, how do you get the albuterol in the ET tube during cardiac arrest? And I would say it would need to be nebulized, not squirted in out of the vial, correct?
Correct. Yeah, you got to have a way to give it via neb through that ET tube. Correct. Don't squirt it down the tube.
Well, I see a lot of people kind of rolling their eyes at that question, but it wasn't that long ago that we were giving liquid drugs down the ET tube.
You're correct. And to clarify that, there are still some folks that have attempted to give medications down the ET tube. And remember, don't really recommend that now. We got access we can get with the IO. And also, the other comment to that is an iGel or a King is not an ET tube as well. So I'll leave it at that. Great talk, Dr. Sullivan. Really appreciate it. I would agree. The bicarb talk was great. We kind of talked in the past about a couple schools of thought on bicarb. Just remember, if you're working at Birmingham, if you're given bicarb, that empty calcium box should be laying on the ground next to the patient first, right? And then the other thing to remember is that National Registry checkoffs for the med director are in March. So if you're an agency that UAB is the medical director for, make sure you got your EMS challenge certificates, your proof of attendance submitted to National Registry so we can look at those and check you guys off before the end of the cycle. So that's all I got.
Thanks, Dr. Sullivan. Thank you, Dr. Ferguson. Great lectures as always. Dr. Ferguson, we're in Calera next, I believe, on January the 14th, and then we'll be in Springville later in the month of January. But we wish everybody a Merry Christmas before we see you the next time. And please remember to fill out your attendance form. If you attended with us online, you can catch the link in the Q&A section. The password for today's attendance form is the word critical, all lowercase. And that'll do it. We'll see y'all next time.